Depression is a common condition that often remains undiagnosed and untreated. We all feel sad or lethargic every now and then, and we have all felt down or even desperate at some point in our lives. These phases are a normal part of life, and people usually feel better again after a while. But things are different for people who have depression. These people often feel like they are stuck in a deep, dark hole. They feel cheerless, worthless, and there is sometimes lack of motivation and self-confidence. This can make it difficult to do everyday things like going to work or studying. Friends, family, and hobbies are often neglected by these people. They do not sleep well. This makes family and friends feel worried, anxious, and helpless. In this video, we will discuss everything about depression you need to know. What are the symptoms or what a depressed patient feels like, how it is diagnosed, what are the risk factors, why this happens or the pathophysiology, and various treatment options available. This is an educational channel on which we provide medical information for all the medicos around the world. We do not recommend or advise or promote any kind of drug. Kindly seek help from your physician or psychiatrist in case of any symptoms. So welcome again to Intellect Medicos, where learning is made easy. I am Dr. Chirag Madan, working as an intensivist ICU consultant at Apollo Hospital, New Delhi. So now let's dive into this topic. According to the DSM-5, that is Diagnostic and Statistical Manual of Mental Disorders, 5th edition, the diagnosis of major depressive episodes, it requires 5 or more symptoms to be present within a 2-week period. One of the symptoms should at least be either a depressed mood or anhedonia, that is loss of interest or pleasure. Also, there could be significant weight loss or appetite disturbance, sleep disturbance, that is there could be insomnia or either hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feeling of worthlessness. There could be diminished ability to think or concentrate, that is indecisiveness. There could be recurrent thoughts of death or recurrent suicidal ideation without a specific plan or a suicide attempt or specific plan for committing suicide. Now coming on to the risk factors that predispose patient to depression, which includes female gender, history of anxiety, history of eating disorders, first degree relative with a history of depression, history of a current drug or alcohol abuse, history of or current sexual abuse or domestic violence. In addition, patients with major medical conditions or with chronic medical conditions, they are at greater risk in fact of experiencing depressive symptoms. These conditions may include cardiac illnesses like myocardial infarction, coronary artery atherosclerotic disease, or arrhythmias. And it could also include cerebrovascular disease like after a stroke or TIA. There could be patients after having diagnosed with diabetes, chronic lung or renal disease, patients with cancers, or patients having a chronic pain disorders. Now the underlying pathophysiology of major depressive disorders has not been clearly defined. Clinical and preclinical trials, they suggest a disturbance in central nervous system serotonin, that is 5-HT activity as an important factor. Other neurotransmitters implicated include norepinephrine, dopamine, glutamate, and brain-derived neurotrophic factor. For diagnosis, screening instruments are used. Self-report screening instruments for depression include the following. First, Patient Health Questionnaire 9, that is PHQ-9. A 9-item depression scale is used. Each item is scored from 0 to 3, providing a 0 to 27 severity score. Second, Beck Depression Inventory or Beck Depression Inventory 2 that is having a 21 quotient symptom rating scale, providing a 0 to 63 severity score. Third, Hamilton Depression Rating Scale, that is HDRS. This is performed by a trained professional, not by the patient. The HDRS has a 17 or 21 items, scored from 0 to 2 or 0 to 4. A total score of 0 to 7 is considered normal, while scores of 20 or higher indicate moderately severe depression. Fourth, the Geriatric Depression Scale, that is GDS, although developed for older adults, has also been validated in younger adults. The GDS contains 30 items. A short form GDS has 15 items. Coming on to the laboratory studies which are used to rule out organic causes. As we all know, depression is a clinical diagnosis based on history and physical findings. No diagnostic laboratory tests are available to diagnose major depressive disorders, but focused laboratory studies may be used to exclude potential medical illnesses that may present as major depressive disorders like hypothyroid disorders, etc. Coming on to the most important topic, that is drug therapy in these patients. Treatment most frequently used by primary care physicians are medications, and second is psychotherapy in cooperation with psychologist, psychiatrist or therapist. More than half of depressed patients respond to initial treatment with medications. Medication options are numerous, and treatment recommendations, they should be tailored to the individual patient on the basis of symptom profile, side effect of drugs, comorbid conditions, and previous responses to treatment if available. Most drugs focus on serotonin and norepinephrine levels in the brain, supported by the major theory of depression known as monoamine deficiency hypothesis. Let's not go into that much of detail. Several classes of drugs have been found effective in treatment of depression through increasing the concentration of neurotransmitters, mainly the serotonin and norepinephrine, in the postsynaptic cleft of neurons in the CNS. These agents include SSRI, that is selective serotonin reuptake inhibitors, NRI, that is norepinephrine reuptake inhibitors, and dual action agents that inhibit the reuptake of serotonin and norepinephrine. MAO inhibitors, that is monoamine oxidase inhibitors, they increase concentration of neurotransmitters by inhibiting their degradation. Mood stabilizers such as lithium and anticonvulsants such as lamotrigine, valproic acid or carbamazepine, they play an adjunctive role to antidepressants in the treatment of bipolar disorders. Antipsychotics and atypical antipsychotics, they may play a role in treating depression with psychotic features as well as resistant depression and bipolar depression. However, patients with these conditions, they may be more appropriately managed in conjunction with psychiatrists. Coming on to the non-pharmacological therapies, and the most important out of these is psychotherapy. This is an effective treatment for depression alone or in combination with medications for mild to moderate disease. But psychotherapy alone is not recommended for severe disease. Cognitive behavior therapy, interpersonal therapy, marital therapy, and certain problem solving techniques, they may be effective as treatment or adjuvant treatment in patients with substantial psychosocial stressors, interpersonal difficulties, or comorbid developmental or personality disorders. ECT, that is electroconvulsive therapy, should be considered with appropriate expert consultation for patients with major depressive episodes who have a high degree of symptom severity and functional impairment, or for patients in whom psychotic symptoms or catatonia are present. ECT may be the treatment of choice when there is urgent need for response, such as in the patients who are suicidal or are refusing food and are nutritionally compromised. The major response to ECT is typically achieved within 3 weeks, and also may be useful in patients who are medication resistant or are pregnant. Monitoring and patient education. Post-treatment monitoring should include ongoing assessment of the risk of suicide as well as the incidence of manic or psychotic symptoms, which may develop over the course of appropriate therapy. Monitoring should include measurement of treatment effectiveness, assessing the need to adjust doses, or identify alternative or adjunctive therapies, and should actively assess the patients for side effects. The use of a defined tool may help patients to see a quantifiable improvement in symptoms associated with the treatment and may make patients more likely to adhere to therapeutic regimens. Patient education should include information regarding the responsiveness of symptoms to treatment, the risk of treatment, issues related to suicide, and the recurrent nature of this disorder. Information regarding the birth control and breastfeeding may be important for females, patients of childbearing age. Now, how to prevent this depression? Depression isn't generally considered to be preventable. It can't be prevented. It's hard to recognize what is the cause, which means preventing is actually much more difficult. But once you have experienced a depressive episode, you may be better prepared to prevent a future episode by learning which lifestyle changes and treatment are helpful. Techniques that may be helpful include regular exercise, getting plenty of sleep, maintaining treatments, reducing stress, building strong relationship with others. So this is all about clinical depression. In case of any symptoms, do not hesitate to consult your psychiatrist. If you find this video useful, do hit the like button and share with your friends and colleagues to spread the awareness. And do not forget to subscribe our channel and tap on the bell button to get the updates about our new video. Thank you guys for watching this video. Stay healthy and safe. Take care.